Hello and welcome to Hard Copy, coming to you from our studios in Abuja. I am Terry Ikumi. A few days ago, on the 1st of December to be precise, the World AIDS Day was commemorated. There were reflections both on the progress that has been made against HIV as well as the considerable challenges that remain. In Nigeria, last year, the revised Strategic Framework 2019 to 2021 was launched, aimed at supporting the fast-tracking of the national AIDS response by urgently communicating the most essential new findings and providing renewed strategic guidance. As the world looks towards the 95-95-95 target by 2030, which means that by 2030, 95% of all people living with HIV will know their HIV status. 95% of all people with diagnosed HIV infection will receive sustained antiretroviral therapy, and 95% of all people receiving antiretroviral therapy will have viral suppression. What progress has been made since the release of the 2018 HIV survey report, and what impact did COVID-19 have on the fight against HIV/AIDS in Nigeria? My guest is the Director General of the National Agency for the Control of AIDS, NACA, Dr. Aliyu Gambo. Dr. Gambo, welcome to Hard Copy.
My pleasure, Terry.
You've been at the helm of affairs for over a year now. That's nice. So tell us now, give us a quick overview on the fight against HIV and AIDS in the past year since the release of the 2018 survey report.
The fight against HIV has gotten a renewed vigor in the sense that the release of 2018 survey results revealed a lot of things. It revealed the huge impact the program has made, over the last 15 years, which we were unaware. It also set a base for us to look forward and monitor trajectories to see progress on indicators of interest, just like you've mentioned, 90, 90, 90, 95, 95, 95. These programmatic indicators of interest are that globally we look and we monitor to see our march towards epidemic control. Reason being, if you're able to identify 90-95% of individuals that have HIV and make same proportion on treatment, and at the same time ensure that they achieve viral suppression, what you succeed in doing is you get like 86% of all the people that live with HIV in your community, in your country, have their virus kept within them and denying the virus the opportunity to leave them to affect other people. So by so doing, you drastically curtail the occurrence of new infection. People who are HIV negative will continue to be HIV negative, and people who are HIV positive will continue to suppress the virus, will continue to deny the virus the opportunity to grow in them. And if that is done, it means the virus cannot leave them to go to another person. At the same time, the virus cannot give them the bad look.
I noticed that the 2019 report has not been released, even though it was expected. And I don't know if that gives you an opportunity or denied you the opportunity to assess the level of progress from the 2018 report.
We have had, we track, we have indicators of interest that we are aware of, and we don't need to wait for a report for us to know where we're going. And that was the basis of the survey, and that is the basis also for the tracking of these important monitors of interest. These are 90, 90, 90, 95, 95, 95. One thing we know is from that time until today, we have made tremendous progress in terms of identifying those individuals that have not been identified. Individuals who are with us, amidst us in our communities, but don't even know they have HIV. And maybe some of them know they have HIV, but they don't come forward to take the medication simply because maybe they have fear or stigma and discrimination, by people that live with them or people that provide these services. And some of them know they have, and they don't have any issue with stigma, but they just don't want to continue taking the medication. So all these people are tricks of allowing the virus to grow in them, and also they are tricks of giving it to others. And these are the kind of people that we are going after now, to make sure we identify them, to make sure that they know that they have a role or a responsibility, you know, in helping, you know, to address this issue or arrest the spread of HIV. And also, one thing, to make sure that they don't allow the virus, you know, to give them sickness, to give them illness, and also ultimately lead to death, because that's what HIV does.
We will take some of the details of the 2018 report side by side much later. Well, let's talk about the target. It was initially the 1990, which expected that by 2020, at least 90% of people would have been identified, put on antiretroviral, and the viral load suppressed. Did we achieve that, or what level of progress did we make? Did we make? Because 2020 is almost gone, or do we attribute some of the challenges to the COVID-19 pandemic?
Not so, but one thing that is of interest here is we never know where we were with respect to 1990 until the last 2 years. It was the last 2 years that we had near or much precise estimation, one of the number of people that live with HIV/AIDS in this country. Before we were thinking, our estimation was given us a number like 3 million, 3.2 million. But last 2 years we were able, you know, to make this estimation more precisely, and now know that we're dealing with a number that is less than 2 million.
What's the figure?
1.8 million, around that range, 1.8 million. It could be 1.7, it could be 1.9, but 1.8 with this kind of margin of error between 1.7, 1.9. With that, then we know that to date we have identified about 1.3. If you look at the gap, we have a balance of about 400 to 500 people, 500,000 people to identify before we will feel within us that yes, we have attained the 90, and then we're going beyond 90. We are progressing to 95. We are at about 73% of the first 90 you're talking about. And of the second 90, based on the 73% we have, we're almost there. We're 89%. For the third 90, based on the 73% we have, we're almost 78%. So you can see, in terms of our march towards 90, the first 90 is the one that determines the rest of the 90s that follow, because it is on the first 90 that the calculation is always made. So we are about 73%, and we are hoping that if we maintain the current momentum, we are confident that in the next 2 years we will reach the 90 target with the first 90, and probably by the time we are at 90 with the first 90, we should be 95 with the second 90. But the first 90 is the one that determines the number of people that.
So you're positive of 95 by 2030?
Sure, even before 2030. If we maintain the current momentum and we get the cooperation we are seeking to have, you know, from the general public and from individuals that are at high risk of acquiring HIV and given HIV, I bet you maybe by 2025 we should be fine.
Well, there's an issue of mortality rate, which I think needs to be addressed. Nigeria still records quite a high mortality rate. Why do you think that is so, despite some interventions that have come in?
It's because of our population. You know, our population, even the size of the number of people that have HIV in this country is the size of a country, some country in Africa. So you can imagine we're about 200 million, and some countries are 5 million, less than 5 million. So for a country that is just 2 million, our size of the number of people that have HIV is equivalent to the size of that country.
So it doesn't suggest that there's a lacuna somewhere which we probably letting loose, which could suggest that maybe we're not paying attention to treatment. Maybe people are not paying attention to treatment or coming forward to test.
Okay, there is that gap, and this is the gap we are we are working hard, to fill. Simply because if you don't get tested for HIV, we will not know that you require our prevention service or you require our prevention and treatment services. Prevention package, helps you to remain HIV negative for the rest of your life if you test HIV negative. I keep on telling people, if there's anything that you can describe as a pyramid of success, the base being 0, and when you come to halfway, 50%, by the time you continue to go to the tip of the pyramid, it's not going to be easy. Simply because the people you easily identify are the people that are easily identifiable. These are people, when you call for tests, they will respond. When you ask people to volunteer, they will respond. But as you climb up the ladder, you realize there are a group of people that, one, will not want discussion about HIVs, will not want to hear about it, and will not want to submit themselves to testing or treatment, simply because they don't believe in it.
Where does the pre and post exposure prophylaxis come in here in terms of transmission? Because it would seem that that information is not really being disseminated, and from my understanding, it is very critical in tackling HIV/AIDS.
The post-exposure prophylaxis is mainly for healthcare providers, those ones who mistakenly got exposed to the virus in the course of their work. But the pre-exposure prophylaxis is the one that helps in terms of preventing or denying the virus, to leave individuals that we know has it or is at the risk, high risk of getting it, of getting the virus. What this means is that if you look at a couple, one is HIV positive and the other is HIV negative. The one that is HIV negative would want to remain negative, and we want to make sure that that will remain negative for the rest of their lives. So this person that is HIV negative qualifies for pre-exposure prophylaxis, because if you give this medication will ensure they prevent the virus from growing. Even if it gets its way into this individual, it wouldn't have the opportunity to establish itself in the system in such a way that you say this individual is infected. When you continue to test this individual, the individual will continue to be HIV negative.
Despite sexual intercourse between both of them.
So, but the other are the people that are at high risk, and these are the key affected population. This is where our focus and attention is now, because they are the drivers of HIV in our society. We know from the 2018 survey that HIV is not growing among the general populace, but is growing among key affected population. And simply this is because of behavior. So in this category of individuals, we want to emphasize pre-exposure prophylaxis. We want to make sure that the prevention packages are well entrenched and people are aware of it. And we want to make sure the combination of treatment and prevention are also well entrenched in some of them that turn out to be HIV positive.
So let's talk about the possibility of a couple, one being HIV positive and the other being HIV negative, giving birth to a baby that's negative.
Sure, 100%.
How does that work?
That works. Even, you see, the gateway to having a baby that is HIV free is for the mother to test for HIV during that pregnancy. If the father has HIV and the mother doesn't have HIV, the baby will never have HIV. The baby is at risk of having HIV only if the mother has HIV. And this is what, going forward, we'll want to campaign down to the grassroots.
So the pre-exposure prophylaxis doesn't work in that case?
No, you see, it works. In that case, the mother is started not only on pre-exposure prophylaxis, but full-fledged, treatment, because she's HIV positive. And what we do is to ensure that during delivery and after delivery, the baby remains uninfected.
Very well, then. I think we can take a break here. We'll be right back after this short break. Stay with us. Welcome back to Hard Copy. My guest is the Director General of the National Agency for the Control of AIDS, NACA, Dr. Aliyu Gambo. And we're looking at Nigeria's progress and challenges in the fight against the HIV epidemic, just as the world commemorated the AIDS Day on the 1st of December. Dr. Gambo, we had just finished talking just before the break about the possibility of having an HIV negative child despite one parent being HIV positive. Draws me to the question, we still have a high rate of mother to child transmission. What's the statistics on that?
What we realize is you can actually not force people to come to a facility to deliver, but we can work our way through to find them, where they feel comfortable. For those that don't come to a facility to deliver, we can reach them at their homes, by the health worker that go to take delivery, because people believe in calling their neighbor health worker in us that, work in some hospitals and say, there is somebody that is about to deliver, come and help us,
okay.
Or the traditional birth attendants. So what we're doing now, looking forward, is to train these traditional birth attendants, to train the community health workers. And when they take this delivery, or they know there is a pregnant woman here, they ensure that that pregnancy is tested for HIV. And if it is positive, they make it a duty to link that pregnant mother to our services so that that baby is protected.
Let's go to testing just before we touch on antiretroviral therapy now. Many medical professionals have canvassed mobile testing, self-testing to help fight this scourge. Is that something that you support, and how are you going about it?
It's not the only we support. It's something that I was out there 2 days ago or last week. Last week and 2 days ago, I was out there demonstrating how this test work. And, it's easy. You can use blood, or you can use saliva. The one I demonstrated, because it's easier, to do, is the one that you use your saliva. You just rub your gum and then turn the other side of the stick and rub your lower gum. And now choke the stick in a solution that is given to you. Wait for 20 minutes, less than 20 minutes, you see the results. You see one line, it shows that it's HIV.
Is that solution available on shelves of pharmacies?
Yeah, we believe even if it is not available, it will be available soon, because, the people that are marketing it, have taken interest in bringing more into the country, and we want to work with them to make sure that it is available everywhere, so that people can do this help. They give us their contribution. The contribution we want people to do, to give to us to control HIV, is just use 2,000 naira of your money, buy this kit, sit down in your room and just test yourself. If you are positive, then call us. We will handle it for you.
Speaking of testing, we know how important state governments are to this. The memorandum on need to ensure the availability of viral load testing for all PL-HIV persons, that's persons living with HIV, in all states, was not approved by the National Health Council when your predecessor was there, Sani Aliyu, and that was because state governments did not have adequate capacity to establish viral load testing centers. What impact has that made on testing in Nigeria, and what engagements have you had or planning to have with the state governments to improve that?
So this is the positive impact of COVID-19 on HIV. COVID-19 has negative and positive impact on HIV and vice versa. The positive impact of COVID-19 on HIV is that now we have more of these laboratories than we had before. Before we had like 22 testing centers, less than 25. Now we are talking of 70 plus, testing centers. And luckily enough, all these centers are located within states-owned facility. So now states are better equipped, to run their viral load testing and also run their program. And this is where we are leading to. We want state to be in the driver's seat, going forward, because this is very, very important for sustainability. We know the funding we are getting, the support we are getting, is not going to last forever. At one time, we will have to take over entirely.
That would
And
mean government.
yeah, government.
But what's government's commitment so far? Does government show any sign of committing? Because it would seem that 70% of the funding you get comes from donors.
Yeah, government has made tremendous commitment in the last 2 years or 3 years. Since after the release of the NIAS survey, His Excellency the President asked us to push for the last mile. And he didn't leave us like that. He gave us the necessary backing. And this means resources. We've doubled the number that we are treating as government from 50,000 that we treated last year. Now, this year, we are treating 100,000. Next year, we'll be treating 150,000. So that is in itself, is a commitment that inspire confidence, in the minds and the sides of our stakeholders and our supporters.
Let's go to treatments now. Some persons living with HIV still complain of having to be made to pay for the treatment. Is this treatment still free?
The treatment is free, but people always have choice. If you go to a private facility, you don't want crowd, you want privacy, you want confidentiality, and you want to make sure nobody sees you when you go to take this medication. Ultimately, probably you have enough resources in you, to do it by yourself, and which is commendable. If you go to this facility, they will definitely charge you, and you can't blame them for charging you because they offer these services for free. But in our facilities all over the country, that is government, that is some of them religious, faith-based, even some of them private, these services are given free of charge. You don't pay anything for the medication. You don't pay anything for the test that is done. The only money that people may be asked to pay are additional tests, not the tests that have to do with the virus, but the tests that may have to do with maybe the medication, maybe the signs that they have some liver problem, or they may have liver problem or kidney problem. The doctors must be sure that they don't have such problem, and if they have such problem, is it contraindication? Are there contraindications to the medications that the doctor wants to give? If there are, then the doctor will be cautious and give patient what the patient needs.
Very well. Just before we go, the 2018 survey reports suggested or indicated that northern states were doing well in terms of HIV prevalence. There's no 2019 report, so we don't know the state of things, but you have said that you've continued your work, and despite the fact that there's no HIV survey reports, that you understand the workings. How has it worked in the north?
Okay. It is still the same way, and it's going to continue, most likely going to continue the same way, simply because, HIV as a disease is tremendously impacted by culture and behavior. And where the behavior and culture is influenced, especially by religion, which is seen in most of the northern states, you find out that this thing is low, the transmission is low. But where behavior and culture permits, risk-taking, you see it high. And but despite that, we're working with those states that it is obvious they have high prevalence, and it's obvious that the transmission is taking place there.
Do you think that religion and culture is responsible for the low prevalence rate in the north?
Definitely that has an impact.
All right.
Religion and culture has an impact on the low prevalence in the north, because the way of life is very important, in HIV transmission. But you see, we've seen also states, that have taken precaution measures and are doing well, despite the fact that, those states are more freer in terms of risk-taking individuals, are more freer. The concerning thing is that, you think that the education, awareness, should play a role. And the role of education we are seeing here and the awareness is low when it comes to behavior, because behavior is very difficult to change.
I'd like to say a very big thank you to you for coming to speak with us on Hard Copy, Dr. Aliyu Gambo, DG NACA.
My pleasure, Terry. Thank you.
Well, that's all the time we have. Thanks for staying tuned. Send your feedback to the email address and social media handle on your screen. And for more, go to channelstv.com and find hard copy. There you'll also find our podcasts. I am Terry Ikumi. Goodbye.